Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome to Airway Answers. I am very excited for this episode today. I have three amazing people in the sleep, dental, orthodontic, airway field here. I'm going to have each of them introduce themselves and we'll get started on the topic, questions. Today's topic is about how early physiology, access to care, and long-term health all intersect and how we can move forward without blame, without oversimplification or unrealistic expectations for ourselves and for our patients. So let's go around and do introductions. Dr. McCarty, you're in my upper right-hand screen. So you want to go first?
Sure. Thanks, Nicole. It's a pleasure to be here. And hello, Kevin. Hello, Stefan. My name's Dave McCarty, and I like to say I'm a recovering primary care doc because that's where I started my journey in medicine. I started in primary care internal medicine, and I fell into the sleep rabbit hole kind of quickly because I was managing a lot of refractory hypertension where I was. So a lot of people were really showing me end-stage disease back then. But I got interested in sleep, and the further I got into it, the more I wanted to do it. So I kind of brought my primary care heart into sleep medicine. And now what I'm doing is I have two different projects. I have an educational project called Empowered Sleep Apnea that I co-created with Dr. Ellen Stothard. And that is it's an attempt to bring the complexity of this large beast called sleep apnea to a larger platform, to more people, and in a way that can be shared across silos. So it's a patient-centered type of complexity deconstruction that we all can share with our patients. And my other role is I'm the chief medical officer of a clinical project called Rebus Health, which is an attempt to be a larger ecosystem that kind of connects all the silos of sleep medicine, including integrative medicine and airway-focused dentistry and behavioral sleep medicine, all kind of with one workforce and a shared language. So,
thank you so much for being here, Dr. McCarty. Dr. Decker, would you like to go next?
Hi, I'm Stefan. I'm a German orthodontist sitting in London. So I'm not by choice really in the UK. I was moved here 10 years ago for private reasons. And in Germany, I was trained actually quite holistically doing orthodontics, functional orthodontics. Airway wasn't a thing 20 years ago. But basically, when I came to the UK, I figured out that most orthodontists don't actually treat children. So for a while, I focused on adult treatment. And then about 6-7 years ago, I discovered the passion for children again. I was approached by Kids Clinic in London. And since then, I'm back in my passion field, helping children. But at that time, I was a classic orthodontist who took teeth out, who did braces, whatever it is. And then I got in contact with my wife, who's a dentist, who said to me, have you seen your cases failing 30 years after you treated them? And I realized, no, what does she mean? So I figured out with John Coyce in Seattle in Washington, I understood what dentists see when they see adult patients, when they're failing. So then Airway came into it. So I went to John and said, look, John, most of the adult cases you're treating in the center, they have tongue ties. The tongue sits low, the upper arches collapse. That's why the teeth are moving. That's why they have abfraction, trauma. And he looked at me and said, what do you mean? So this was the start of everything. And then I got connected to a friend of mine, Christian Leonhard, another German genius dentist. And since then, we basically try to figure out, okay, the adult sleep apnea is something we can measure fairly easy. We have certain measurements, we sleep test, the measurements in the cephalmetric, CBCT. But when it comes to children, we don't have so many things to measure on when do kids have sleep apnea. So I look at all of my patients and I look at certain signs in children that I see, venous pooling, palatal architecture, things like this, where I realize, oh my goodness, we don't have so many data in children to help children detect the early signs. And we know, we will talk about all the consequences sleep apnea can have on children and their behavior. So since about now 3 years only, my focus is to help children in UK worldwide to get access to early preventative orthodontics, because a lot of times airway is due to small oral cavity, tongue posture, things like this. And now talking to these genius here, Kevin, Dave, this is so important because sometimes an orthodontist is not the first point of call where kids and families should be, is myofunctional therapy, Nicole. So I think it's very important that dentists take responsibility, especially the orthodontic community, to at least screen children for these things, and then to at least advise them what could be done. Also fairly minimal, expensive, because like while Kevin is here, he's heard one of my podcasts with Nicole. I said, it feels like health becomes a luxury good for children, because when I would do perfect orthodontic treatment, I need a lot of body workers with me, myofunctional therapists, ENT, all of these disciplines, because it's multifactorial. And in London, everything has a big price tag, and most families can't afford it. So now we are stuck. Of course, we want to help the children, but they fairly can't afford your bills. So what we're going to do now, and I think this will be a big part of this discussion, is what can we actually do to help families in need who might not have the financial circumstance to afford us? I think this is really big for me, because my passion is helping children one way or the other.
Yes, thank you so much for being here. And Dr. Boyd, after you introduce yourself, I'm going to talk about what inspired this episode with my interview with Dr. Decker and a recent essay that Dr. Boyd and Dr. McCarty just wrote. So we'll get into that. Let's hear about you, Dr. Boyd. Tell everybody who you are.
Yeah, I'm Kevin, pediatric dentist in Chicago. I entered healthcare as educationally qualified as a dietitian. I have a master's in nutrition and dietetics, which has really come to serve me quite well, as the first half of my career was very conventional in pediatric dentistry. I did a lot of restorative dentistry, what I call putting out sugar fires. Tooth decay is 100% preventable. It is very much diet driven, but that's for another talk. I think a lot of malocclusion and comorbidity with respiratory problems is also highly preventable, if not completely preventable, but getting in early. And again, to build on Stefan's introduction and really love for caring for children. Children is a term, and people say kiddos a lot, and as if it's a monolithic block. If it's the American Association of Orthodontists definition, it's birth to 18 years old. So really, somebody can be 1 minute away from being able to go into the military or legally vote and still be called a child. So I really like to qualify children. What I treat is under 6 years old. Mainly, my practice has become highly subspecialized in children under 71 months old, which means they have not yet turned 6. And that comes from the Academy of Pediatric Dentistry, who identifies tooth decay before the age of 6 as something called ECC, early childhood caries. Well, I think we should also start changing the lexicon a little bit and start talking about early childhood malocclusion, as it does not self-correct. It will become more complex. I don't say worsen, I say become more complex, and either is or will become comorbidly associated with sleep and breathing problems. So that's really been the last 15 years of the last half of my career since I've been discovered by pediatric neurologist and sleep medicine specialist Stephen Sheldon from Lurie Children's Hospital, who was very, very frustrated that physicians, pediatricians, family physicians who saw kids, they weren't really assessing risk for sleep problems. So he said, heck with it, and I'm going to start recruiting dentists. And he started training us in sleep medicine assessment, validated risk assessment. And now the American Dental Association is behind it. The rest is history. We just have to make this available, like Stefan said, to everybody. And I started to say, penicillin is now available to everybody. It's inexpensive and anybody can get it. But when it first came out, it was, probably $10,000 a pill. We're somewhere in that transition. It's a luxury good. And I'm so glad you opened with that, Dr. Decker, because that is really what we're going to be about. So anyway, let's go, Nicole. Thank you
Yeah, let's do this. Thank you all for being here and donating your time to really have this conversation. So this episode did grow out of a moment in a recent podcast interview I did with Dr. Decker. It was episode 66. And towards the end of that conversation, you did say, Dr. Decker, you said, health is a luxury. And you were talking about something many of us see every day, that comprehensive airway and sleep care often requires access to multiple providers, a lot of time, money, long-term support, and that not every family has equal access to all of that. So you talked about speech and myofunctional therapy, allergy doctor, ENT, orthodontics, dental treatment. And you said the saddest thing about everything is health is a luxury good. And the earlier you catch it, the less money it costs. And then after that episode, Dr. Boyd did comment on the comments section of that podcast. And you said, this needs to be a bigger conversation. So that kind of inspired me to reach out to both of you. And then just the other day, Dr. 𝐃𝐈𝐒𝐂𝐋𝐀 and Dr. Boyd published an essay exploring how neurodevelopmental traits like ADHD type behaviors may act less as fixed diagnoses, but actually early signals of long-term physiologic stress across the lifespan. So I started getting into this, and I have this summary typed up, and I just hope everyone bears with me because I'm debating, do I just read this or not? But I feel like it was so impactful for me that I need to read this. So if I'm boring you, just like mute me for 5 minutes. It might take like 5 minutes, but I want to read this because I read your essay.
Do it. Come on, do it.
So at the center of that essay is a large UK birth cohort study that followed children for more than 4 decades. And what the researchers found was that children who showed high levels or higher levels of ADHD type traits, things like inattention, impulsivity, and regulation challenges, were likely decades later, like 40 years later, to carry a greater burden of physical illness in midlife. That included conditions like metabolic disease, asthma, migraines, chronic pain, disability, and overall poorer physical health. What was important is this research was not about ADHD as a diagnosis, because most of these children actually weren't even labeled as having ADHD. And the authors were really careful to say it's not about blame, pathology, or destiny. Many people with ADHD traits do live long, healthy lives, but there were consistent impacts that remained accounting for these long-term lifetime health impacts. So Dr. Boyd and Dr. 𝐃𝐈𝐒𝐂𝐋𝐀, what they did in this essay, and I'm not sure if you guys have read it yet, if not, they'll tell you how to access it, is you reframed how you interpreted those findings. So rather than asking, does ADHD cause disease, they ask a much more interesting question. What happens when a nervous system that struggles with regulation, hyperarousal, and attention issues has to navigate modern life for 40 or 50 years? In that framing, ADHD traits are understood not as a disorder, but as a form of neurodevelopmental vulnerability, a signal that the body may be working harder to adapt. And adaptation works until it doesn't. Over time, those adaptations can quietly shape physiology, and decades later, the bill may come due not as ADHD, but as hypertension, metabolic disease, chronic pain, disability, shortened health span. In other words, they frame these traits not as a disorder, but as an early signal of physiologic strain across the lifespan. This is very impactful for me. This is why I really want to delve into this, is because I'm personally struggling with such issues with one of my children. So being a provider and a parent, I'm deep in this also. So I understand these feelings and the stressors. So the essay is also very careful about what the research does not show. The studies did not directly measure airway, anatomy, sleep quality, breathing patterns, inflammation, craniofacial development. So the authors are not saying that airway issues cause ADHD. And I've seen a lot of providers do quote that misinformation. And they don't say fixing the airway resolves all of these neurodevelopmental challenges, which I think we need to be cautious of saying that and thinking that. They explicitly warn against this oversimplification. What they do say is that many of the known pathways linked to long-term illness are deeply intertwined with sleep and breathing. This we know, right? Craniofacial structure, or Dr. Boyd names the craniofacial respiratory complex, is modifiable. Malocclusion is not always thought of, or we don't think of it as a cosmetic issue, but more a developmental footprint. And we know these red flags like narrow maxilla, retruded mandible, posterior tongue, low tongue, dental crowding. They're not just alignment issues, they're spatial and functional compromises. So from that perspective, airway and sleep aren't a single cause, but they may be biologically foundational contributors in some individuals interacting with environment, genetics, and life experience over time. Things like chronic mouth breathing, fragmented sleep, and subtle airway obstruction in childhood may influence inattention and emotional regulation early on and then drive those compensatory physiology for decades. So not as a single cause, but as part of a complex moving parts system. And the article talks about how adults with diagnosed ADHD may live on average less lifespan, 7 to 9 years less than the general population. I did not know that, but likely due to modifiable risk factors, not the ADHD itself, but risk factors. And Dr. Boyd also sent a couple articles talking about dementia. Research increasingly recognizes oral health as relevant, but largely overlooks the cranial facial development, sleep disordered breathing, suggesting that we may be looking too late instead of looking upstream. And one of the most powerful ideas from your essay that you wrote is the concept of adaptation and how the body adapts to stress, long-term stress from poor sleep, inefficient breathing, which is not just sleep breathing, but also daytime breathing and constrained structure. And that can, create a physiologic quote unquote bill that comes true over time. And one other important part of your essay that I really took away was there's a strong emphasis on agency rather than blame. And that distinction really matters. And I actually looked up, what does agency mean? And this really hit home. So I want to read this part too. When we're talking about blame, it looks backwards, asking what parents or patients did wrong. Agency looks forward, helping people understand what's modifiable. It says, this is not your fault. You're not too late. Understanding physiology gives us options, not guilt. Blame is thinking, you should have caught this earlier. You didn't do enough. This is your fault. Even when it's unspoken, families hear it and it shuts people down. But agency, looking forward, helps people understand this is not your fault. It's not too late. When you know the physiology, you have options. It says this helps explain why the body adapted the way it did. Now I'm reading this, but I'm thinking of one of my children at the same time. And it's kind of like a relieving feeling when you're deep in the heart of this ADHD sleep struggle. Understanding that there's modifiable pathways. This is not destiny. You didn't cause this. You're not too late. Agency is not about promising cures or overselling early intervention. It's about restoring understanding and choice. So when we talk about this in this episode, we're going to bring together several threads. The idea that health itself can function as a luxury, like we started talking about. And the reality is that not every family has access to comprehensive care, but we want to intervene early because that is very important. And the responsibility that we have as clinicians, therapists, doctors is to avoid oversimplification and also despair. The goal isn't to offer simple answers, it's to open better questions and to explore how we can support families with clarity, compassion, and realistic pathways to help them move forward. And in your essay, you said, if early traits shape adult bodies, what happens when we intervene earlier? Not just with labels or medications, but with form, function, breathing, sleep, structure, environment, and understanding. So let's just get into this. Let's start out by talking about all your views or thoughts on health being a luxury and how that hits home. Dr. Boyd, what made you comment that we need to have a deeper conversation about that?
Well, it's like we were saying at the beginning, all these people are flying to London, to see Dr. Decker. And, we've got a lot of people that don't live in Chicago that come from far away. There needs, and I don't think that it's not that they don't want to help children. They don't understand that really adult problems, they have their origins perhaps even in utero, much less the first 6 years of life, 5 years of life. So I just sort of, when I heard Stefan talk about, that health is a luxury, and he talking about the National Health Service there, and you have to go private if you really want to get comprehensive care, and it's very expensive, and who has access to it? And here in Chicago and everywhere, there's just so many kids. If they have one parent, most often a mom who's working 6 jobs and trying to raise multiple kids, she just wants to feed them. And what's available? Really bad food. The standard American diet, SAD, SAD. And guess what? You don't have to chew it. Kids don't have to chew anymore. Masticatory competence doesn't develop in early childhood like it has our whole existence. So I don't know. I just like, oh my gosh, I want so much more to talk about this. And I really would like to explore ways that we can reach more children. I have collaborators in Chicago. Stephen Sheldon, I mentioned, is a pediatric sleep doc. Darius Lagmani is another one. We are trying to make this available to everybody. So I don't know. That's why I just wanted to get involved.
I mean, I want to comment on that. Like Kevin, I think, like when you look at the language, I think it needs to start with education, that we all have the same language, what we're talking about. Because let's just look at dental language and orthodontic language. A dentist has a completely different objective to achieve than an orthodontist. Because if you look at Airway, more and more dentists, especially US, talk about airway assessment. And the ADA, you mentioned the community, ADA says the dentist should check for airway obstruction. The Pediatric Association should check for it. But the AO in America says, if you can, it's okay. If you can't, it's also okay. So the language from dentist to orthodontist is already so different that this is the first problem. And so we need to have the same education, that everyone understands each other, not fights each other. What's currently happening, all of the ENTs don't have a dentist in their board. They speak their own language. Like, it's really frustrating that nobody sits together on a table and says, this is a human being in total with different issues, different adaptations and compensations to a problem. Let's try to find the same language, because then we can talk. But this is actually not happening. Instead of that, all the disciplines try to protect their discipline and fighting each other. Now, you dentists, you're not good, but you orthodontists are also not good. We're not progressing anywhere with this attitude.
I got to hand the mic over to Dr. McCarty, because I'm feeling some vibes from you, because you are the language guy, Dr. McCarty, right? Tell us.
This is called product placement. That's
well, he's writing and Dave, bring up your other essay that you're working on now. It's amazing.
That's my my sort of logo, that my happy E is the empowered sleep apnea logo. And everything Stefan just said is what I believe in my bones. I was an English major in school, and I like to talk about that because I care about the meaning of words. And this fundamentally boils down to, how do we answer? We, I meaning the collective we, right? As human beings providing care. How do we answer 3 fundamental questions, right? What is sleep apnea? And that's a slippery one we can get into. What else could this be? That protects you from falling into the cognitive trap of that diagnostic label once you get there. And then finally, if it is sleep apnea, why should we offer stabilization? Why should we try to do something about it? What are the reasons, right? So if you really drill down, this has been my journey over the last 5 years in understanding how people talk about these issues and why people really need to fight with each other, Stefan, right? You can get people going just by talking about Airway. Isn't that weird? And the reason is we've all developed different language. It's a language problem. So the Empowered Sleep Apnea Project is about trying to find a language that we can share with our patients, because there's that word agency. If our patient is going to participate in the decision-making of an emerging complex system, what do I mean by that? That means that you can't tell from the beginning how things are going to go. I have sleep apnea, go. And like, some of us are going to do fine on CPAP. Some of us are going to have a terrible response, and CPAP might actually be harmful, right? So how do you tell from the word go? You often can't. And so that means it's going to emerge over time, you see. So that's called an emerging complex system. And what that means for our patients is that they're going to participate in the decision-making, then they need to be cottoning on to the contingencies of each decision that they make. which means that ideally our patients also have an understanding of how big this playing field is and what the moving parts look like, right? So that's a real challenge. Teaching complexity, I've come to understand as a teacher my entire career, teaching complexity is fraught with peril, because when one teaches a complex subject to another human being, there's two possible responses. It's either going to scare them and they'll shut down, in which case they'll say, "Oh, person in the white coat, just tell me what to do." Or if that person has some understanding, they'll feel out jargoned and it'll make them mad. And they'll think that you're trying to pull something over on them if you're talking down to them. So either way, it's a hard place to be when you're trying to teach someone something that they can use and engage with and really sort of express curiosity for. So that's my pitch. I'm all about helping to answer those three questions in a way that we all can kind of hold hands. What is sleep apnea? What else could it be? And why should we treat it? So
and I think, Dave, in that aspect, social media is good and bad. Social media is good because more and more parents are aware there is something out there that could justify the behavior of our children. But on the other hand, in social media, people get shown certain treatment solutions which cures their sleep apnea. And then they're coming to you in an office, says, "I want this because then I can breathe." And like you said, it's so multifactorial. It's a playing field. We need to first of all sit them down and explain to them, be a teacher says, "No, it's not as easy as you do this and you can breathe." And this is the biggest issue. Like, you need structure, you need good education, you need professionals coming together saying, "Okay, let's try to make decision trees. What if that happens?" And for that, we need to sit together collaboratively to make these decisions.
I do have a question related to that and sort of that thought of ADHD and airway, because that's what that essay was geared from, ADHD type research. And if we're oversimplifying, we might say ADHD, it's just airway, or fix the airway and everything else resolves. So how do we communicate this sense of urgency to patients and parents without reducing it to not being something complex and heterogeneous? How do we not bombard the patients and parents with all this information and not overwhelm them, but also let them know it's important to seek early treatment, but there's so many different factors?
So I can address that, because this is what we're actively taking on with the Rebus project, is how do we roll this complexity out in a way that makes sense? And our answer has been, we're attempting to introduce a different flavor of medicine that we're calling narrative-based medicine, rather than as opposed to label-based medicine. So we're all talking about, oh yes, sleep apnea is a bad thing, and we have all kinds of reasons to worry about it. But the truth is, it's a spectrum, and everybody who experiences it is going to have their own personal experience for why they might want to take something on that is going to alter this unstable breathing pattern. So the second question here, after we ask what is sleep apnea, what else could it be? And this is a focus on the narrative. Whatever we're talking about, that person comes in with a story. They're not satisfied with their sleep-wake experience. And for the kids that we're talking about, the waking experience is marked by a lot of daytime neurobehavioral impairment symptoms, attention deficits, behavioral problems, school problems, things like that. Not necessarily daytime sleepiness, but daytime neurobehavioral impairment that has received a label, because there's a way to do that. You can label that, you can put them on meds and they feel better. So they get diagnosed sometimes they don't, but they're daytime neurobehavioral impairment symptoms. Meanwhile, they might have some sort of impairment to the nocturnal experience that is yet to be disclosed. So the point here is, everybody's got a story for why they're not fully satisfied with their sleep-wake experience, right? And if we say, okay, we're going to start with that narrative, then we can use a complexity deconstruction tool like we use here at Rebus, called the 5-finger approach to sleep-wake complaints. And that's a published complexity deconstruction tool. I wrote this paper back in 2010. So it's published in the peer-reviewed literature in Journal of Clinical Sleep Medicine. And what this is it's a checklist. It's a way of saying, okay, we're starting with a narrative, folks. Now, what could be causing this? The thumb is circadian misalignment. So there's a lot of interest in this now. Your sleep-wake cycles are messed up. It can certainly give you daytime impairment. The index finger is pharmacologic factors, things we're taking, drinking, and smoking. Middle finger is medical factors. Being vitamin D deficient can give you daytime neurobehavioral impairment symptoms, right? So we want to make sure we're not missing something. The ring finger is psychiatric and psychosocial factors. So we now know and can appreciate that the PTSD-like physiology is also a spectrum. And a lot of people are dealing with this type of thing. So again, impaired sleep, impaired wake, could there be a psychiatric, psychosocial, or behavioral component? Probably, okay? And then finally, the pinky finger is for primary sleep diagnoses, which would include sleep apnea, okay? So the point of this whole exercise is, A, to introduce the idea that for most people with nonspecific complaints, there's more than one thing going on. And B, to introduce the idea that there is a method, that there is a strategy that you can go through that we can actually share with our patients. So when we're talking through this, we can say, this is how we kind of go through this. So we're going to be talking about your schedule. We're going to look at your med list. We're going to think about your medical problems. We're going to think about your mental health and well-being. And then we're going to talk about the sleep apnea. It's a way to put it in a whole context that we all can enjoy and kind of agree on.
And for a child that's having neurobehavioral issues during the day, one, how do you know it's due to poor sleep? Do you think, we need to get a sleep study? That's how we know. And then how do you address all those factors with a child? I can see it's easier with an adult because they can talk to you and you go over that, but
I have an easy answer for you, Nicole. Clinically, if a child is neurobehaviorally impaired during the daytime, you should assume something's wrong with their sleep. So if a child is malnourished, you should assume they're not eating the right kinds and quantities of foods, okay. Kevin, right? So if a child's not operationally on board in the daytime, that is, sleep is the brain's recovery. So,
and I think one of the initial things to rule out is structure. Is there myodysfunction? And if there is myodysfunction, there is malocclusion. It may be very subtle, but if there's myodysfunction, and this is, my anthropology background pretty much says we don't really see appreciable malocclusion in the fossil record. We just don't. If a child had antecedents to myofunctional disorders, they wouldn't live long enough to develop a malocclusion. So that's why we see them either die of predation, infection, starvation, but their jaws were perfect. These kids that died in early childhood or even in utero, their jaws look really good. So I'm just saying that we are hardwired for excellent, optimal myofunction and optimal craniofacial respiratory structure. We just are.
No, not everyone agrees with you, Dr.
I have a visual aid for this point here, Kevin.
Yeah, he's my advisor. He's the one who came out of retirement to help guide me and Mariana Evans.
1999 is how long we've known this. So it's over a quarter century that we, meaning the collective we, our scientific community, has understood that malocclusion is not genetic, that it's environmental, and it has to do with the way we chew, breathe, and swallow. And nevertheless, the conversation about how do we reverse engineer these deficits, it's still one that feels controversial,
Yeah, well, it's funny because I'm talking with an orthodontist right now, and we're like, let's develop maybe a screening tool for orthodontists to use to help identify what patients need to be referred for myofunctional therapy. Because he's telling me, you're saying all orthodontic patients pretty much have soft tissue dysfunction. If you're saying malocclusion is rooted in underlying, he said, well, no, I'm just going to believe that. That's an oversweeping generalization, and you're going to get no buy-in from the orthodontic field if you say that.
Right.
So how do you react? Do you kind of say, okay, let's try to break it down to more complex cases like open bite, mouth breathing, or do we
Nicole,
say,
I can say you something very interesting in that. So Chris and I, we digged a bit deeper in the orthodontic history because we are bound by Mr. Engel. Everything needs to be moved into class 1, Engel class 1. So when we look at history in 1899, when the malocclusion classification has been introduced in Dental Cosmos magazine, Engel introduced the class 1, 2, 3, but he also stated that the class 2 malocclusion is caused by nasal obstruction or lip dysfunction. That was in 1899. So our whole profession is based on Engel, and Engel knew Airway has something to do with it. But over the last 125 years ago, this functional part got eliminated because it's much easier to move into class 1 and forget the breathing and the malfunction, dysfunction. So this justified the whole orthodontic profession. So we need to have our own identity, move everything into class 1, forget airway, forget function. But Engel himself knew it, but we just choose to forget it. That's our own history.
So
yeah, Engel had in his office a skull called Old Glory. And if you look this up, Stefan, I'll send you, orthodontic textbooks had Old Glory in full view photographs in textbooks up until about World War II. And he called class 2 distal occlusion. So it was completely understood that distal occlusion was due to myodysfunction. Dr. Rogers, the orthodontist who, I learned about that from your profession, Nicole, but he used a prehistoric perfect skull with erupted wisdom teeth in front of the ramus, and that was his ideal, Dr. Engel. That's where he came up with it.
Old Glory was a pre-industrial skull.
Yes, it's probably estimated to be about 1,000 years old.
That's brilliant.
He had in his
Brilliant.
office.
So his ideal was the full genetic potential of our genetic forebears. And what we're seeing all around us is something much more limited than that.
Right. And genes hadn't been identified yet. I mean,
Well, Mendel was happening just about the same time as Engel, which is, I think, where the genetics explanation for malocclusion started to get really exciting for everyone, because there was Mendel was, of course, published way earlier, but there was a resurgence of interest in Mendel because of another person's work. And I can't remember the name now, but the point is genetics seemed to explain everything right at the same time that Engel was doing his work.
Yeah, it was, it's been pretty much, I don't know if it's 100%, but there's evidence to suggest that Mendel's book lay on Darwin's desk after he had died, and it was still in the envelope. He never opened it. And Darwin suspected it. He called them gemmules. He didn't know what genes were, but yeah, there was co-discovery going on then. And then this whole epigenetic phenomenon was speculated as early as the late 50s, 60s, and then now it's really come into its own. So yeah, it explains a lot.
Ladies and gentlemen, I need to bounce to another call. I'm delighted to be a part of this conversation. Thank you, Nicole.
Thank you so much.
I just want to say that essay that you read, Nicole, Dave, I sent him a paper, and that essay was almost perfect. When I got it, I made a few little, additions and things, but that was, the body of that was Dave and his language skills, and I am just so grateful for your talent, Dave.
I always tell everybody that the secret to being a writer is just to have conversations with people smarter than you, and then write short sentences.
Wait, one thing. I just need to capture this before you go. If a child is having daytime behavioral issues, we can pretty much assume there's a sleep problem. Is that how you said it? I need to listen to that again.
I would say if any of us that are having daytime neurobehavioral impairment symptoms of any flavor, we need to assume there's something that is possibly wrong with our sleep. It's a simple thing for me. Sleep is our restorative time. And if we're not restored, there's possibly a good reason why.
Thank you. Thank you for that.
Well,
That's really good information.
And I guess we never said this, but you can find the essay in question on the Empowered Sleep Apnea website. That's empoweredsleepapnea, all one word, .com. And it's under the Dave's Notes tab, because that's the blog. So thank you, everybody.
Thanks for being here.
I'll talk to everyone
Thank
later.
you,
Thank you.
Dave.
Thank
Thanks.
you so much. All right.
I want to go back to history because I know Kevin is so interested in history.
Yes.
So
I am.
Charles Tweed was a student of Engel.
Right.
And he didn't like the facial profiles of Engel that he produced. So this is where Charles Tweed introduced extraction protocols and cephalometric tracing to justify his way of finding beauty. And since then, we never went away from it. So Engel himself was a really good guy, but afterwards, what happened in history, we just forgot all the rest. And that is where we're ending up now. And now nobody knows about Airway. Now we are the enemy mentioning Airway in orthodontic profession. I mean, it's just quite sad.
Well, how do you guys feel, or how do you think I should handle that if the orthodontist is trying to teach and mentor other orthodontists and come up with some system, at least for referrals for myofunctional therapy and understanding that aspect, says that you can't say nearly all orthodontic patients need myofunctional therapy or need a referral for an evaluation because you're going to lose all of them. They're not going to believe you. It's too, black and white. How should I respond?
First of all, I think we need to get away from the term orthodontic, okay? Do you know, Stefan, David Hamilton, who used to be editor of the Journal of Orthodontic, the American AJO it was called, until Tom Graber from Chicago suggested we should call it the American Journal of Orthodontics and Dentofacial Orthopedics. And that got incorporated before, the year 2000. And if you look up David Hamilton essay, and I'll send it to you, and it's called The Emergence of Dentofacial Orthopedics. And he wrote this beautiful essay about how we really should not talk about orthodontics, which means teeth, okay? We should, even you're an orthodontic specialist. I would change your name to an orthodontic and dentofacial orthopedic specialist.
Then you have to read all your sign, your business cards. It's a lot of work.
And it really does. It just subconsciously conjures up. And I don't think the conventionally trained orthodontist and conventional, the orthodontic industry, I think they would like to just leave it orthodontic because it is embedded in the culture. It just conjures up straightening teeth and straightening permanent teeth. And so I really think it's another word to add, but I think we have to introduce it into the lexicon. And it's only going to come about if we start using it and, that's going to be confusing. Well, good. A lot of good things start with confusion, don't they? And we educate the public, especially moms. I'm sorry, but when little kids are seen in healthcare, at least in America, in England too, I know this because I did part of my training in the UK, which I'll tell you about sometime, but parents always have to be with children in the operatory. That's where I learned that. Not everybody here in America likes to have parents back with them. I learned that during my externship when I was in Wales, North Wales, and it was always, if a kid came for a dental visit, the parents were always there, and I became very comfortable with that. So I just think it's something that, and I say moms, most encounters by healthcare professionals who see children, whether they're pediatric dentists, orthodontists who will see little kids, general dentists who we call primary care dentists now, who will see children, family physicians, pediatricians, ENTs, that if you're seeing children, you're going to have most of your encounters with female adult caregivers. That's a fact. And that is just something that I've come to know, that if we can get the female adult caregivers aligned, policy gets changed. It just does. And dads will come along. Yeah, well, and I'm starting to see more dads in my practice now. I'm always appreciative when I see a dad there. But I don't know. Do you agree, Stefan? Is it that way in the UK, in London?
Yes, I mean, for me, all of the children come with their parents, absolutely. And from that, but what I realized, especially last 3 years teaching a lot, like when I did my orthodontic specialist academy in order to teach orthodontists what I do in early prevention, I came to a realization that the orthodontists are not coming to the training. They are not interested in that. So what I figured out is who's coming are pediatric dentists and dentists. So also during my career with John Croix, I figured out that the dentists who do orthodontists, they do it because the orthodontists don't deliver the care they would like to have. For example, Christian, he did orthodontic training after dental training because he
Mhm.
wanted to move the teeth in a different position than the orthodontist wanted it from an airway perspective, but the orthodontist didn't care. A pediatric dentist sees the problem in children, but he doesn't know what to do. So you see all the malocclusions in kids, but you don't know what to do. You refer to an orthodontist who only sees the kid for 3 years. They never see the problem early. They never see the problem 30 years later. They don't ever see the problem because they have it only for 2-3 years in treatment. This is a big, massive problem. So when the pediatricians, the pediatric dentists should do it. And where does prevention start, Kevin? You know, prevention starts when we want to conceive a baby, because if a mom lives a certain lifestyle and is full of toxins and the barrel of water is overfilled, how can these stresses affect the growing baby? How can you conceive a baby in the first place? What's happening to mom who suffers from sleep disorder breathing? How can she provide good oxygen levels to a brain that is developing in utero? That is where it all starts. So prevention starts when you want to conceive. So
Well, and not just the woman, but preconception, the gamete coming from the male, is he's got to take care of his sperm. That can also impart some bad connections with the twin zygote. I mean, you know, men who drink, who smoke, their sperm is damaged. And it's not always everything, the burden is on the women who are carrying the child. And of course, they shouldn't drink or smoke. But no, men have to take a much stronger role. I know you agree with this. I think we talked about it when we were in Italy together. But I just, right now, another thing, Stefan and Nicole, is that this term children, it's a monolithic term. And I think that we should start saying early childhood as opposed to middle child, late childhood, early adolescence, not all in one swoop, but my focus is early childhood. And what does that mean? Well, that means that child is probably just entering into the 3rd year of life or about to be 6 years old. It's that area where it's a complete primary dentition. And usually by 3, every kid is in, 20 teeth, and they start somewhere before or by 6 in the 6-year of life. They're starting to get permanent teeth. Well, that is the window where I think we should be paying closest attention, but not everybody has to do it. They just have to. I didn't learn this in my pediatric dentistry training. I went to the finest, at the time, largest pediatric dentistry fellowship in the world, the University of Iowa, largest teaching hospital in the world at the time. And we produce more dental educators in pediatric dentistry than any other program on the planet. That's why I wanted to go there. Okay, I wanted to do research. I wanted to be an academic. Well, they didn't teach that malocclusion is very subtle in early childhood. But guess what? Because a child gets taller, it doesn't mean things above the clavicles are also going to get wider and more forward. Is that if you have a distal step molar, and Dr. Bashara, Sam Bashara, taught me cephalometrics and growth and development. And he taught us that once a distal step molar, always a class 2. A distal step molar in a 3-year-old will always turn into an advanced skeletal class 2. Always. Now, what is the most common malocclusion phenotype comorbidly associated with sleep and breathing problems? Distal occlusion, class 2. And McNamara says, if you got a class 2, you've also got maxillary transverse deficiency, with or without a crossbite. You do not need a posterior crossbite to diagnose maxillary skeletal transverse deficiency. You have hypoplasia in the transverse and sagittal dimension that shows up before the age of 6. Okay, this is not taught to pediatric dentists. It's not taught in dental schools. Also, pediatric behavior guidance, managing expectations of children, managing their anxiety, managing the parents' anxiety. Only pediatric dentists get that training, and pediatric ophthalmologists. We are the only 2 disciplines in healthcare that get advanced training in child development, anxiety. We call it behavior guidance. Okay, child psychology. We had hundreds of hours of didactic and in clinical training, in managing anxiety. You guys don't get it. I know orthodontists don't get it anywhere in the world. If you're a parent, my theory is you can be retrofitted. If you're a parent, orthodontist, chances are when you did your training, you weren't a parent yet, or maybe you were just starting out as a parent, and the only parent training you were exposed to was how you were parented, which may have been good or not so good. I don't know. But anybody doing, anything on a child, I learned how to manage anxiety when I was giving shots, when I was doing extractions, when I was doing pulpotomies. I used to do all that stuff. And you know what? When I started doing orthodontics on 3 to 5 year olds, are you kidding? That was easy compared to what I had to do when I was trying to, a kid comes in with an abscess so I don't know. Those are things I think that we have to pay attention to. Dental education, pre-doctoral, dental school doesn't teach. We're not preparing people to see children. We're just not.
I think coming to that, Kevin, I think we need to understand adaptation mechanisms in the teeth, because if you understand why we develop a curve of Wilson, why do we develop a curve of Spee, why do we develop no tongue, no teeth space in between diseased dentition, it has most to do with the tongue. The tongue that's not developing the maxilla, hence if the maxilla is not developing, the mandible responds to that situation. So it's all about trying to teach people these early adaptation signs, posture adaptations, tongue adaptations, teeth adaptations. Because the minute you see one of these adaptations, you can say, now we're out of sync, we're out of balance, now we can intercept. And the younger you catch, like you said, Kevin, you as pediatric dentist, you have the huge power. You are the superhero because you can stop it there and then. So in my personal opinion, if orthodontic community continues the way they're doing and pediatric community picks up their game in education, you have such a huge responsibility to detect these things early, treat them early, so that hopefully there will never be an adaptation problem, at least in the craniofacial complex. Hence, posture and all the rest will be fairly okay, because airway, posture is highly linked. So posture adaptation is airway because we need to protect the brain. So I think it's so important that the pediatric community gets all of these teaching of early adaptation mechanisms in children.
If the orthodontic departments would say, look, I want my residents to go into the pediatric dentistry program and start taking it. I had to take cephalometrics and growth and development with the orthodontic residents, but the orthodontic residents did not have to come and learn pediatric behavior.
That's the mistake. This is the mistake.
I'm glad. Do you agree with me?
Have you both listened to the recent debate with, it was Audrey Yoon and Jeremy Emanuele? And then did you okay. I just listened to it right before this interview right now. So it's
I don't know it. Please send me a link.
We need to share with you. It just posted like yesterday or the day before. So
my God, I can't wait.
Audrey Yoon, Jeremy Emanuele, orthodontist, and then 2 non-airway, but they don't like to call it airway orthodontics, and that's not the right term necessarily. But what Jeremy Emanuele was saying is that we need to obviously stop looking at teeth and look at the bones, look at the skeletal structure. And they were talking about expansion. And he said the maxilla should be 3 to 5 millimeters wider than the mandible. And he does CBCT on all of his patients. And the anti-airway person was saying, so are you saying that's the new standard of care? Every patient needs CBCT?
Hold on, Nicole, I will stop you right there. It's not about data measurements of 35, 25, 24 plus age, whatever. We have a muscle in the mouth, which is called a tongue. And that tongue should sit in the roof of the mouth. And the tongue size can vary, because when we have a higher BMI, the tongue is bigger than a smaller BMI. So at the end of the day, we need to expand the maxilla enough that the tongue can fit in the roof of the mouth. And that can change every year, because our BMI can change, our muscle tone can change, our tongue restriction can change. So it's not a set standard. You can't say, okay, a teenager with 30 millimeter intermolar distance is going to be fine. because it might have a small tongue, it doesn't require so much space, might have a bigger tongue, needs more space. And when they grow older and they gain in weight, this tongue needs suddenly more space, so we suffer from more problems. So this dogmatic thinking of having, I need X amount of millimeter of tongue space is nonsense.
So how would you quantify that for who needs early intervention?
Your job, Nicole, is to get functionality of the tongue correct. In order for you to get functionality, you need enough space to get function. Because when you give an ENT the go-ahead to release a tongue restriction, you need to make sure they can do suction hold, correct? So if the tongue can't fit up there can't be released. So basically, Christian has a really nice analogy. He says a car is the tongue. In order for you to park a car in a parking spot, you need an engine in the car, which is the muscle. So you need a big enough parking space. You need a strong engine in the car, but you also need to check if the car is towed to a wall with a chain, a rubber band, or a tow. So you need to check at everything. It's not as simple as, oh, I give you a 3-meter parking space, the car will move there automatically. No, it won't. If there's no engine in the car, it will not move anywhere. If there's a chain attached on the car, it will not move anywhere. So, and it can change. Sometimes we change the car from BMW to a Mini. That means I need a smaller parking space, or I go to a van. So it's changes.
So how would you quantify that for orthodontists that need they need numbers or information? Are you suggesting maybe have the patient do?
I don't need numbers. I need function, Nicole. I need
right.
function.
So I'm saying, like, how would you have an orthodontist evaluate that so they know whether the patient needs expansion? So you would suggest orthodontists have their patients do a lingual palatal suction and measure if the tongue is fitting in the palate. That would be the way to quantify that.
If the tongue can be sucked to the roof of the mouth with enough space that we don't have tongue scalloping.
Okay.
Okay, so now listen, this is real important. I think what you're saying, both of you, this is like, if I was a cat, I'd be purring right now. What I like to tell parents is everything that you're saying is beginning in utero, the tongue, by chewing amniotic fluid, is building itself a nest to live in for the rest of its life, but it isn't completely built. When they're born, they must develop masticatory competence. And again, it was vital to survival until fairly recently. The orthodontic industry wasn't really a necessary thing except for really wealthy kings and queens and gentry. But the proletariat, which is most people, they wouldn't survive childhood unless they were on-demand nursing into the 3rd year of life and eating everything that an adult was eating by 1 year old. That was required, and that is in the fossil record. They know radioisotopic data, looking at teeth and bones. They can tell when a child, through 5,000 years ago, at what age they were fully weaned. Okay, so we really need, the other thing we need to understand is above the cranial base, selenasion, okay? How does that cranium grow? Because of the brain. The brain grows the cranium. Well, then I tell parents, remember the soft spots, the sutures, fontanelles on a baby's head? Lick your tongue on the roof of your mouth. Feel that line up there? That is a fontanelle. That is a suture. And just like the brain grows the cranial vault, the tongue grows what I call the palatal facial, sutural complex. It's like a group of fontanelles, all those sutures that are in the facial complex. I call it the craniofacial respiratory complex. It's one thing that all interacts. So this is a great conversation. We obviously get it, but we haven't always known this. I don't know, Nicole, maybe you came out of your training knowing all this. Probably not. Stefan, you've admitted you were a conventional orthodontist. I was a conventional pediatric dentist. I did a little crossbite correction, but I was drilling, filling, and billing. I was putting out sugar fires my whole career and making a really good living at it. That is also a thing, that there's people that are meeting a public demand by seeking out straight teenager teeth, and kids that are in pain, and it's a good thing to get them out of pain from tooth decay. But we could prevent all these things. I don't know, Nicole, as an SLP, conventionally trained, maybe you could have probably made a great living, by just doing that. And I don't know. I fell into it.
I have to say to you, what feels much better than just moving teeth or drilling decays, helping decays, is that you have an identity, that you know why you're doing your profession. And you and we all three sitting here, we know why we're doing it, to help people, to ask questions, and not accepting the status quo says it can't be that simple. And most of us have their own story. Nicole has a kid. I have a kid who nearly died in my arms, who had tonsil infections every month. So there's all a story. And we were the people who says, the traditional medicine doesn't give me the answers to that. And then when you start opening the textbook, like you, Kevin, will go in history thousands of years ago, you think, hold on a minute, there's something not adding up. There's a much more. And the more books you open, the more you think, oh my goodness, what happened to us? What happened to our training? And then you feel bad because you dig deeper and you know more things that you don't know.
I try not to be judgmental because I haven't always been this way. And it's sort of like, I don't know, I got lucky by virtue of sitting next to Stephen Sheldon, the neurologist sleep medicine doc, at a faculty meeting. And we just started talking. And the next thing I know, he's asking me to write, the dental perspective on sleep apnea in his pediatric textbook that's used all over the world.
And Stephen Sheldon says that ADHD in many cases is a sleep disorder.
Yes.
Yeah. What do you think about that?
And he and I both started digging in. You brought up the dental cosmos, Stefan. Most people haven't even heard of it. That's the precursor to the Journal of the American Dental Association. But I can send you articles, and one of them is a list of something called inattention that happens when adenoids grow back. And from 1913, they knew this. They called them rhinologists. They weren't called ENTs. And it was, orthodontists and dentists who did orthodontics. They were collaborating with rhinologists. That was almost standard of care. And then it all fell out in World War II. Something happened in World War II.
You see,
I don't know.
You go back in history and suddenly you think, it all happened before.
Yeah.
So I have a question again. So if you're noticing that your way of evaluating tongue space function, or whether there's a dental facial abnormality like the palate is too narrow, how do you let every patient, the parent, know that you're seeing this issue? What if there's no other symptoms? How do you recommend that child needs expansion or not?
You don't need a symptom. You need malocclusion will persist. And if it's not, it may have subtle signs right now, and you don't want to wait till they're not subtle. So malocclusion will persist. And Stefan, this is something that I can't wait to share with you. Maybe you already know this, but I learned it from Mariana Evans, who is a dual boarded periodontist and orthodontist. And we've been looking at skulls for almost 20 years at the Penn Museum. And she came up with, look, even if these kids don't have obvious airway symptoms, guess what? If those incisors are allowed to come in crowded, they are going to be at risk for adult-related, age-related periodontal disease when they're older, because they are not erupting in solid collar of cancellous bone. And the longer you wait, the more susceptible they be. And now research shows, and I gave a talk in the UK. I wish you would have been there at that SDGF group. It was called Geriatric Medicine for the Pediatric Dentist. Is that periopathogens are in the brains of demented Alzheimer's patients. So indirectly, you could speculate, look, even if they don't have airway symptoms, they have reliably persistent hypoplastic skeletal malocclusion traits in the sagittal and the transverse dimension, and they could become at risk for periodontal disease. So please,
You're
it's going to
saying
get more complex to treat.
they both become more complex. And that's what Audrey Yoon brought up in that debate about periodontal disease. But the orthodontist who was anti, he's like, so are you saying that child already had periodontal problems? And she's like, no, but it's a risk factor. He's like, well, there's not research on that they're at risk
Yes,
for
there
periodontal.
is. Yes,
So
there is.
you're going to be really fired up. I don't know if I should even send you that debate because you want to yell at the debate, but it's frustrating because it's such a black and white way of thinking.
Nicole, I want to answer your question. You said, what happens if there's no symptoms? Yeah. What I say to parents is, there is no symptom yet. But
Bingo.
what I will say to them is, but this and this can happen. So if at the moment the parent will decide, okay, I'm not going to do anything because of financial, whatever, costs too much money, there's no reason. Trust me, Nicole, the minute the symptom appears, they will be back in the office.
Yeah, it's almost like you're putting the word out there, just letting them know. And I had a parent, this was a long time ago, but this kind of stuck with me, a potential referral. I'm speaking to her over the phone, how I'm saying mouth breathing and snoring is not normal. Mouth breathing may be common, but it's not normal. It's not optimal. And she's like, well, I don't need my child to be optimal. That was what she said. How would you respond to that? I feel like it just threw me.
Well, I was wondering, that's fine. Everyone can have their own opinion. I would just do my duty of care, say, advise them the oxygen level will be less than nasal breathing. I will give her some education. And then it's up to her. If she, after the education, still believes that's okay, then, okay, what can you do? You can bring the horse to the water, but you can't make it drink.
Yeah, did I say something wrong by using the word optimal?
No, listen, Nicole, you said, what could I say to somebody like that? And I'm telling you as a pediatric dentist, what you say is, you know what? You're that child's mother, and there's no one in the cosmos that knows that child better than you. I respect maternal instinct. And if your instinct tells you as a mom that you don't need optimal sleep and breathing, there's something that you must know that I don't, and I respect you, and I will support you in wanting to serve your child the best way you can. I am here for you. If this makes no sense to you, I totally respect you as this child's mother, and I am not trying to be a co-parent. Please know that. That's all you can do, and it's the truth. You just say that. You're not out to win a debate on this. You did beautifully there. I would just add that to it if you encounter that.
And Nicole, very often, especially in my profession, you have to imagine at the beginning of this career with children, the kids come in because of a tooth. So they say, my tooth is crooked. So that means for me, they don't know anything about why the tooth is crooked. So that means I have to be very gentle in easing them in, because I always ask them, do they know anything about me and my philosophy? If the answer is no, I have to be super careful, because if I say you didn't feed your child right, that is why the teeth are like this, they feel plain. So you have to really understand where they're coming from, and then how deep you're going to go. Because this level we are talking about, you generally don't talk in the office, because the people come for a reason of teeth, in my perspective. Now more and more come for airway, but you need to be sensitive. And if they say, no, I don't want that right now, that's okay. But you just advise them what could happen in future. And if it happens, I'm here for you.
Okay. That's a good way to think of it.
Period.
And
That's a great, well stated statement.
I'm here for you. I'm here for you. That's really, really nice. And, this is multifactorial. We've talked about this many times. It's not just fix the dental facial orthopedic structure and all issues will go away. Oftentimes they need to see ENT, allergy doctor, myofunctional therapist. And we talked about how that can cost a lot of money. It's a lot of time. So what if a family can't do everything? What do you feel are the highest impact, lowest cost interventions that are still meaningful enough to move the needle?
I say, as a dietitian trained, I'm not a dietitian, but I have a background in nutrition and dietetics. And I'll say, you know what? The number one thing, whether you're in treatment with me, want to be in treatment with me, about to be in treatment with me, done with treatment with me, have your child habitually eat 4 F's, firm, fresh, fibrous food. Kids are sucking their food down. They don't need to chew it. And if you want my orthodontic results to have long-term stability, if you want to do something preventive that you can't afford to, and I don't use that term, but you've got 6 kids and you've got 3 in treatment and the other 3 can't do it yet, I get it. At least get them eating firm, fresh, fibrous food. Minimize ultra-processed food. There's a book written by a British London-based pediatrician called Ultra-Processed People. Van Tulleken, do you know about it? It's a great book. And I really do. That's simple. That's a form of myofunctional therapy. It really is.
I would
kids
add
to chew.
a second stimulus, Nicole. Try to focus on breathing. So if you chew proper food and you're breathing, you have the 2 key stimuli for growth there. So breathing doesn't cost money, chewing doesn't cost money. Because the first thing you do when you're born is breathe. The second thing is chew. So if these 2 stimuli are fulfilled, you're going to be okay. So that doesn't cost a lot.
Yeah, it really doesn't. And it really, the firm, fresh, fibrous food, we have things called food deserts here. And these are lower socioeconomic areas that have a lot of fast food and McDonald's and, convenience stores, but they don't have great access to fresh fruits and vegetables and markets. Plus now under Trump, without being political, farmers they're being put out of business. So getting fresh and organic meat and animals that aren't caged and egg, it's so hard to get it good food. My daughter, she wants to be a farmer now. She just worked for a big company. She resigned. She's going to graduate school to learn how to be an industrial farmer because she, this is like a whole thing that is consuming me now. Food as medicine. Have you heard about that movement in healthcare? Food as medicine. Our careers are coming together. My 27-year-old daughter, and I'm going to be 71 next month, and she and I mean, oh my gosh, she's so far ahead of the curve. Anyway,
So
I
we're
digress.
breathing mode, our diet is so important. What about other stressors beyond airway sleep?
Say one more thing. When you look at traits of autism, primitive reflexes development is another key thing. So that in children, we need to make sure that they fulfill the primitive reflexes, that they use chewing muscles, they don't skip crawling, lifting their head. So these primitive reflexes, these connections to the brain very early on, they're very crucial in a lot of developmental problems.
How do you incorporate that into your practice in London?
I can't. I work with someone who specializes in primitive reflexes.
Well, that's what I meant. Who do you work with? Who is that? Is that like Katrina Rogers? You know Katrina, right?
Yes.
Katrina Rogers. She does that, right? I've heard her talk about it.
There's also 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐿𝐿𝐿𝐿 Tamayo. There's a few in London, but this is a big thing. But again, it's a price tag. Like this costs a bit of money.
That's what I was going to say. It feels overwhelming. That's expensive. There's a lot. So now we're adding in not just airway, not just ENT, the orthodontic piece. We're talking diet. Okay, now we're adding in primitive reflexes. Got to work on that. And physical therapists might work on that, or somebody special trained craniosacral therapists. It's a lot. It's very overwhelming for families to have to manage all of this.
But
so
food and breathing is free.
Food and breathing is free.
The actual consumption of food is free, but not buying it.
Right, that's true.
Air is free. Air is free.
Okay, so maybe we've already answered this, but I'm just thinking for clinicians who are listening, what is our ethical responsibility when we know what optimal care looks like, but we know families might not be able to afford it? How do we sequence the needs and the treatment plan? We kind of talked about this already, but how do you?
That's a hard one because this is the discussion what my wife and me have a lot of times. Who is a poor child? Who is not a poor child? Who do you give treatment? Who not? Like It's hard. I think for me at the moment, what I do is by gut feeling. If I feel a child is in need and I know there's no financial means, I will just do it. But that's based on my gut. But the bigger everything goes, the more people come in need, the more I can't just do it by gut because I need to qualify and justify why I'm doing it. So what we have actually, the idea is to give some content out for free and ask for donations to generate a certain income, a charity income, which we then can use to help more children. But that's just an idea we're having. It's a hard one because I don't know, Kevin, how you deal with it. I mean, do you say, what do you do?
Why We Know What We Know by Simon Winchester is the book I was trying to look up, because it talked about a woman in the 70s or 80s in India who was she wasn't rich, but she came from a highly educated, PhD, parents, professors, and she just set up a school. No, none of these kids in the slums in India had school. It changed the whole India. Everybody gets an education there. And it was because one woman set up just a table and said, I'm going to start educating these kids that can't eat. And it's something like that. The name of the book is Why We Know What, with Simon Winchester. I'll try to find, and some movement has got to start like that, you guys. We understand something and we can help little kids that don't have access. I mean, we're helping kids who can afford it, the luxury.
And there's a lot of people writing children's books. So books that can go out to preschools, elementary schools, to read to children about breathing and mouth posture, foods. I think that's a way.
Also, I think what Kevin just said, India. My wife is Indian. She's from Punjab. And last year in April, I had the luxury to go to visit Punjab and a very rural village. And we did some charity work there in schools. And it was 6 o'clock in the morning. And her uncle, he walks to the temple in the sunlight, kisses the sun good morning, does his prayers, and then he does his donation, walks, and then he does yoga exercises, means tongue exercises and breathing exercises. And I watched him, and for me, it was like, oh my goodness. Yeah. And he said, what you doing? I said, well, what do you mean? I clear my brain. I said, huh? I'm doing that since I was a child. So in rural India, and the children do the same in that school, in the villages, because it's their part of their daily routine. There's no malocclusion, there's no decay, there's no toothbrush.
Wow.
So it's just local produce, and the kids have no issues. Their mental health is beautiful because they have a community to help each other out. It was so amazing for me to see that in these areas where there's no Western European influence, the world in terms of Airway is pretty good.
Yeah. I really, you and I mean, I just need to connect with you on this. I will find this excerpt from this book and I will send it to you. And I would love to, I mean, naturally, I'm an part-time academic, but I want to do research on that village in the Punjab now. I mean, to study.
I come with you, and trust me, because my family is from there, you will have the most generous experience of love and food you ever had in your life.
Can I come?
Yeah, of course. No. Oh my, well, let's talk.
I know we have to wrap up, and I know Kevin will follow through with that. Kevin, you do a lot of amazing things. You guys are both great. I want to summarize some of the things we talked about as we just close, because one of the things that stood out to me from the beginning is how we were talking about ADHD and different diseases that occur as we age. And it's not really about chasing a single diagnosis or a one-size-fits-all solution, but just stepping back and looking at the long arc of how early problems with sleep and breathing, development, environment, foods we eat, how we're breathing, and access all interact over time to impact our long-term health span, lifespan, and health span. And we also talked about health being a luxury, and it's hard for families to access all of these services. If we intervene early in any way possible, we could change that pattern of growth and development and of health. Our health span could change. It's little things that we do. You both talked about it doesn't always have to be these huge, crazy things, but just modifying our way of breathing, breathing through our nose, trying to get our tongue up, chewing, masticating. Those little things can be helpful. If we get this message out to more people, moms, mothers who can take action, schools, we can start making more positive changes that are at lower cost. I mean, imagine if there were programs beginning in preschool age where children sat around for 10 minutes a couple times a day and did some tongue pops, got their tongue up, got their lips closed, read a children's book about
Every
this.
day.
Every day. Little things could make huge differences, not
It's a good
only
point,
in
Nicole.
right, not
Yes.
only in changing muscles and function, but also changing our broader understanding, the child's
And
understanding, the
it
parents'
gives
understanding.
community, because if everyone is doing it, it creates connection, community, and other health benefit, instead of staring into device.
Right. And I think
Yes.
this conversation also reminds us that even when we can't do everything, there's almost always something meaningful that we can do. Also, what Dr. McCarty said really stuck to me as I'm trying to find answers for my child, that I always say it's all sleep and airway. And sometimes I feel like I overdo that, but that is so important. And when a child or adult is having daytime neurobehavioral problems, we always need to look back at sleep. That is such a root cause of so many issues that we have, emotion wise, health wise, that we need to investigate that and investigate that properly. So it's not always done correctly, right? When we evaluate sleep. So we need to really find those answers. Plus, like you said, foods, toxins, vitamin D. There's so many iron, ferritin levels. There's so many other pieces to the puzzle that we really don't want to overwhelm our families, but we want to give them information so they can take the meaningful steps. I don't know if either of you want to just add in, if there's one maybe core message for listeners or hope you have, if you can just throw that out there for us as we end right now. Dr. Decker, Dr. Boyd.
For me,
take
a
away
key
the
thing
message.
is education, that we get out there and we spread the word. If it's at schools, in congresses, whatever, universities, we need to go educate the public through social media, whatever channels it is, that everything is connected. And when education is there, we can make changes. Because if you don't know, you can't change.
Right.
I would say 3 words: chew, chew, chew.
Are
And
you
I'm not
sneezing?
great. I'm not being a train, a locomotive. So no, it's in baby food. There's a book called Inventing Baby Food by Amy Bentley. Read it. It's an expose on the baby food industry. Let your kids start eating, as long as they can sit up and you're looking at them, somewhere between 8 and 10 months. Have them start chewing things, holding things, avocado, maybe hold a pork chop, and get them away from pouches and get them chewing. And if they want macaroni, then make them eat some carrots with it. If somebody hands them one of those pouches, they can use it as a dip celery in it and chew. Use it as a dip. That's my best, really easy advice. But the other thing, I think it's real important to not be judgmental about all this. And it's just, we haven't always been this way. Remember where we came from?
I'm all about, at the time, and you're at the end of your career as well, Kevin, giving back feels beautiful.
Yeah, it does. Well, good, you guys.
Thank you, Nicole, for the invite. Thank you,
Yeah.
Kevin,
Thank you so
for
much.
having me.
Sir.
All
It's
of you,
been-
thank you again so much for all of your time. It just I feel the love, guys. Thank you so
Yeah,
much.
me too.
Thank you.
Okay,
Okay, take
bye,
care.
guys. Bye-bye.
Bye.
Bye. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.